Vanakkam. Who says you cannot learn while having fun? Welcome to the Great TANPAPS Quiz, the infotainment program in the run-up to the annual conference of the Tamil Nadu and Pondicherry Association of Plastic Surgeons to be held from February 9 to 11, 2024.
Question number 1. The surgeon credited with performing the first tube pedicle flap is Harold Gillis, Hugo Ganzer, Emard, Vladimir Filato. The correct answer is Vladimir Filato. Vladimir Petrovich Filato, an ophthalmic surgeon in Odessa, performed a tube pedicle and tested it on a rabbit. When a 62-year-old man presented with a malignant tumor of the lower eyelid, he performed the first human tube pedicle on 9th September 1916, and on the 20th postoperative day, after a delay, he divided the flap and he called it a round pedicle flap. Interestingly, the same concept was independently used by the German otolaryngologist Dr. Hugo Ganzer, who reported a pedicle tube flap from the upper arm to close a palatal defect. In 1917 itself, Sir Harold Gillis performed pedicle flap almost around the exact same time. In 1917 again, Dr. Emard used a tube flap from the chest as a second stage of repair of a nasal defect. Question number 2. Bipedicle venous flap with a vein entering the caudal end and leaving the cephalad end of the flap is type 1 venous flap, type 2 venous flap, type 3 venous flap, type 4 venous flap. The correct answer is this is a type 2 venous flap. Nakayama et al. First described venous flaps in 1981, and 3 types of venous flap have been identified. The type 1 venous flap is a unipedicled venous flap. There is a single cephalad vein which is the source conduit for perfusion and drainage. These flaps can be proximally or distally based. Type 2 flap is a bipedicled venous flap with a vein entering the caudal end and leaving the cephalad end. The flow of blood is from the caudal to the cephalad end. Type 3 is an arteriovenous venous flap that is perfused by a proximal artery and drained by a distal vein. These flaps have had success in hand reconstruction.
Question number 3. Golfer's elbow refers to the following: lateral epicondylitis, medial epicondylitis, dislocation of the radial head, or dislocation of the olecranon process. And the correct answer is medial epicondylitis. Medial epicondylitis is sometimes called the golfer's elbow because in making a golf swing, this tendon, that is the common flexor origin, is stressed.
Question number 4. The person who developed the first laser light with use of ruby crystal in 1960 was Albert Einstein, Alexander, Leon Goldman, Theodore Maiman. The correct answer is Theodore Maiman. Albert Einstein was the first to describe the concept behind the laser in the theory of stimulated emission of radiation in 1917. Theodore Maiman developed the first laser light with use of a ruby crystal on May 16, 1960, which was announced at a press conference on July 7, 1960. Then lasers were used in ophthalmology. Leon Goldman, a dermatologist, used ruby lasers in the treatment of vascular birthmarks. Question number 5. Multiple epithelial malignant neoplasms are prone to occur in the condition shown, which is xeroderma pigmentosum, familial atypical mole and melanoma syndrome, dysplastic nevus syndrome, discoid lupus erythematosus. The correct answer is xeroderma pigmentosum. Xeroderma pigmentosum is an autosomal recessive disorder characterized by intolerance of the skin to ultraviolet light. This is because of the inability to repair damage induced by the sunlight to the DNA. In this condition, the skin is prone for multiple malignancies developing. Dysplastic nevi are compound nevi with cellular and architectural dysplasia. They can be flat or raised, typically larger than the normal compound nevus, which is around 5 to 15 millimeters, with lack of pigment uniformity. Familial atypical mole and melanoma syndrome is a condition where atypical moles can be inherited as autosomal dominant trait. This familial form is known as FAMM. Discoid lupus erythematosus is a chronic skin condition which appears as a red inflamed patch with scaling and crusting appearance. The center may appear lighter in color with the rim darker than the normal skin. Question number 6. Under the VO classification of cleft lip and palate, unilateral cleft of lip and palate is group 1, group 2, group 3, group 4. The answer is group 3. Under the VO classification of cleft lip and palate, which was formulated in 1931, there are 4 groups. Group 1 consists of cleft of soft palate only. Group 2 is cleft of the soft and hard palate. Group 3 unilateral cleft of lip and palate. Group 4 bilateral cleft lip and palate. Question number 7. What is the condition denoted by X? Plagiocephaly, scaphocephaly, brachycephaly, trigonocephaly. The correct answer is scaphocephaly. Craniosynostosis is the pathologic fusion of one or more cranial vault sutures, usually resulting in an abnormal head shape. These are the normal cranial vault sutures that are seen: the coronal sutures, the sagittal suture, the metopic suture, and the lambdoid sutures. In scaphocephaly, there is premature fusion of the sagittal suture. This results in a boat-shaped head. There is expanded anteroposterior dimension and a narrowed bitemporal distance. In brachycephaly, there is bilateral coronal suture fusion which occurs prematurely. This results in bilateral retruded forehead and supraorbital rims and increased biparietal diameter. Trigonocephaly is due to premature metopic suture fusion. It results in keel-shaped forehead, bitemporal narrowing and hypotelorism. Plagiocephaly is a general term which refers to asymmetric coronal plane of the cranium. This could be anterior plagiocephaly, where premature fusion of the unilateral coronal suture occurs, or posterior plagiocephaly, where premature fusion of unilateral lambdoid suture occurs.
Question number 8. In FDP avulsion injury, when the FDP tendon retracts into the palm with disruption of the vincular system, it is classified as Leddy-Packer type 1, Leddy-Packer type 2, Leddy-Packer type 3A, Leddy-Packer type 3B. The correct answer is Leddy-Packer type 1.
In type 1 avulsion, the FDP tendon is retracted to the palm. This happens because of the rupture of both the vinculum longus and the brevis of the flexor digitorum profundus. Hence, it is free from all attachments and can retract up to the palm. There is no attachment of any bony segment from the terminal phalanx. In type 2 FDP avulsion also, there is no bony segment attached to the avulsed tendon, but the vinculum longus is attached. So the tendon retracts only up to the level of the neck of the proximal phalanx region. In type 3 avulsion, there is a large avulsion fracture from the terminal phalanx. Hence, it prevents the tendon from retracting and the tendon end stays at the distal interphalangeal joint region. In type 4 injury, there is an osseous fragment and there is an avulsion of the tendon. So it is a double avulsion.
Question number 9. Combination techniques of avascular structural allograft with vascularized free fibula was first described by Camella, Cavella, Cadana, Capana. The correct answer is Capana. Combination techniques of avascular structural allograft with vascularized free fibula inside was described by Capana. It is used for extensive skeletal defects in young tumor patients. This technique combines the optimal vascularization of the vascularized autologous fibula with the structural stability of the geometrically matched allograft, which is a shell. Question number 10. Non-enzymatic glycosylation of which RBC membrane protein is responsible for membrane stiffening and increased aggregation in diabetes mellitus? Glycophorin A, spectrin, ankyrin, stomatin. The correct answer is spectrin. Increase in blood viscosity is noted in diabetic patients due to stiffened red blood cell membrane and increase in erythrocyte aggregation. The non-enzymatic glycosylation of the red blood cell membrane protein spectrin is responsible for the membrane stiffening and the increased aggregation that occurs, causing an increase in blood viscosity.
Question number 8. In FDP avulsion injury, when the FDP tendon retracts into the palm with disruption of the vincular system, it is classified as Leddy-Packer type 1, Leddy-Packer type 2, Leddy-Packer type 3A, Leddy-Packer type 3B. The correct answer is Leddy-Packer type 1.
In type 1 avulsion,
I hope you liked the video. I enjoyed making it. Please register for the TANPAPS 2024 conference, a wonderful scientific and academic feast where many innovative and interesting sessions are being planned. Do visit the website to see the details and to register. Vanakkam.